Hi, everyone. Welcome. Thank you so much for joining. We are going to go ahead and jump in. We've got a lot of content to get through, so we'll let folks filter in and we'll get started. I am Megan Seawald, manager of the Data and Design Core at the Eisenberg Family Depression Center. And we're so excited to welcome you to the third and final session of our new webinar series, Building a Research Career Using Secondary Data. Today's session is called Advanced Analytic Approaches, and we're delighted to welcome Dr. Emily Urban-Wojcik, the lead statistician on our Data and Design Core team, who works very closely with our Depression Center members to support their analyses using secondary data, and is really an expert in this topic. And so we're so excited that she'll be able to share her expertise with you all today. Next slide, please. So if you are tuning in with us for the first time and you're not familiar with the work of the Eisenberg Family Depression Center, this is just a brief bit of context about our work. So the mission of the EFDC is to improve lives and empower communities through bold innovations and interdisciplinary collaborations across research and outreach that advance how we understand, treat, and prevent depressive illnesses. And under that larger mission, the goals of our program, the Data and Design Core, are to reduce barriers to academic research so that investigators can generate impactful, innovative research more efficiently, and to support emerging scholars so that they can build robust long-term research careers in the field of mental health. And the key mechanism that we use to achieve those goals is secondary existing data. We'll touch a little bit on why that is during today's session, but if you want to hear more, I'd recommend you go back and watch the recording from our first session in this series. Next slide, please. So the first session in this series was called Getting Started with Secondary Data, which featured Dr. Matthew Davis, who's an associate professor in the School of Nursing. There he covered the strengths and drawbacks of different types of secondary data. He pointed to several valuable secondary data options for mental health research and walked through an example of how to take a research idea and see it through to the end of a project using secondary data. Our second session was called Strategies for Grant Writing, which featured Dr. Brianna Mezek, professor of epidemiology and our Data and Design Core faculty co-lead, and Eric Simon, who's a senior technical writer at the Depression Center. And there they covered how to write successful grant proposals using secondary data, including how to amplify novelty and impact, how to write a budget, shared several resources such as how to work with a grant writer, and again, shared several examples. So both of those sessions did touch on things that Emily will cover today. In today's session. You don't have to have watched them in advance to understand the content that we'll cover today, but they do, all these sessions fit together very nicely. So we'd recommend that you watch them if you miss them the first time around, and we will send those recordings around again as a follow-up. Next slide, please. So before we begin, just a couple of Zoom logistics. This is a Zoom webinar, meaning you'll be on mute and off of video for the entire session. So feel free to do whatever you need to do to make yourself comfortable, grab some food, move around. Closed captioning can be enabled at the bottom of your Zoom screen if you desire. We will try to save about 10 minutes at the end of the session for questions and discussion. So please feel free to submit questions throughout the session using the chat or the Q&A box, and we'll answer those at the end. If we can't get through all of them, we will also send a follow-up with some questions that we weren't able to get to. And then finally, the session today is being recorded, so don't worry too much about taking notes. We will send out the recording and the slides and a couple of additional resources as a follow-up in the next couple of days. So with that, I will hand it over to you, Emily, to get us started.
Thank you, Megan, and thank you all for joining us today. I'm excited to give you an overview of using secondary data sources to answer novel and impactful research questions. So to start us off, I just want to reorient you to what we mean by secondary data. We define it as data that is collected by someone else, often for the purpose different than our own, that can be used for a new analysis. So there are many types and sources of secondary data, and many of them are actually freely and publicly available. So these sources are often large, with participant counts in the thousands, even tens of thousands. Many span several years, even decades, and they have a wide array of measures from surveys and genetic sequencing to electronic health records. And some of these sources can actually be used to characterize a population in its entirety. So both the previous sessions highlighted the impact and novelty of using secondary data in research, 2 points that are key to landing grants. Secondary data can be more impactful and quicker than primary data collection in the size of the samples that are available and in the scope of the data that are collected. And it can lead to novel research in many ways, including linking different types of data and different data sets together. And a final point I want to highlight from the two previous sessions that is particularly important is that secondary data are fixed. So that means that we have no hand in creating the materials of the study or targeting specific populations. And as a result, the data preparation and analysis have to be done very thoughtfully and carefully, and sometimes creatively. When using secondary data, the research question and approach often need to be a little bit more flexible because they weren't designed with your specific research question in mind. But that flexibility, having that flexibility is completely worth it because there are many strengths of using secondary data. So now that you're hopefully convinced from our first two sessions that secondary data is worth exploring, let's dive into how you can actually get started. So today I'll give an overview of my workflow of approaching secondary data research projects, including project planning, preparing and cleaning data, and data analysis. And then I'll spend about the second half going through two different examples using this workflow, one using the Health and Retirement Study, and one using Michigan Medicine's DataDirect tool. So all throughout this session, I've included links and we'll mention resources that will hopefully help you on your way. It's meant to be an expansive overview rather than a deep dive into any one thing. So I do include a lot of these links and information, and it might kind of fly by, but hopefully because we're sending out all the materials afterwards and they'll be available online, you can actually go back and find things that are relevant and helpful for you. So on this slide is my typical workflow. It involves project planning, as well as data preparation, pre-registration of analyses, and finally the actual analysis. So this workflow looks very linear, but in practice it's actually quite iterative. So this is the nature of many research projects in general, but especially secondary data analyses. For example, you might ID a data set that you think is going to be useful for your project, has all the variables you think that will be good for answering your question. And then you get to cleaning your variables and you realize, oh, only about 10 people have this measure that I'm interested in. So you have to kind of go back to square one or figure out a different variable in your data set that you could use instead. So this happens quite a lot. You might end up downloading the data many times to get the right combination of variables, and that's all totally normal. Just expect that this is not necessarily a linear process. But let's start with project planning. So my first step with any project is start to write a project plan, and that helps organize all aspects of the project. And we have a template for what a project plan might look like on our GitHub page that this is linked to that you can use if you're interested in. So the first part of a project plan is the rationale. The purpose of this is to help you narrow in on a solid, specific research question. And for some of you, you've already got a research idea in mind or have even secured funding, so this should be pretty quick. But if you're just getting it started, I encourage you to take some time thinking through these prompts. So I'm including a link to a webinar that really talked about this approach quite clearly, and I've included some of the components they discussed there that I use. So I like to start out by defining the problem. What problem are we trying to fix by doing this research? And what's the gap in the literature? What gap are you trying to fill with your research question? What's the purpose of your project? What's the goal? And what is the potential impact of the finding? So laying this all out will help you get started and keep a kind of directed approach to your data analysis. I also recommend writing your project with your eventual analysis in mind. How do you plan to model the data to answer your research question? So even if you don't have the analysis fully formed, it's good to keep it in the back of your mind to make sure everything is focused and that you have the statistical tools to actually answer the question. So once you have a solid project rationale, it's time to find a data source. So when figuring out your options, keep in mind, what are the primary features of your project that are essential for answering your question? Is there a specific age range that you're interested in, specific outcomes? Does it matter if it's across time or can it be cross-sectional? And then what kind of features are nice to have, but you're flexible about? Because you're probably going to have to be a little bit flexible with some of the questions that you're asking based on existing data. So if you don't really know where to start, a good place to go is our dataset resources page, where we outline several mental health related publicly available resources. And you can also request a consultation with us if you are stuck. Once you've identified a source that can work for your project, you'll want to learn as much as possible about the data set. So read through their documentation. They usually have extensive resources like user guides and code books. And if your data are public use, you can actually just download it and start exploring as well. Just keep in mind that these files may be huge, so they could take up lots of space on your computer. Some studies have these really cool integrated analysis tools on their sites that let you look up ahead of time before downloading any data, any cross tabulations. So you can see how many participants have this or that measure, or counts of participants that endorse certain items or have certain conditions. So that's really useful. Once you have a data set in mind, it's time to define your constructs in the context of your data set. So you already have an idea of what you're studying, but what does that look like in the data? And so what variables are you going to use to define things like your primary sample and any subgroups, including inclusion and exclusion criteria, any other independent variables, covariates, and outcomes, and make sure to map this onto everything in your data set. This will make it a lot easier when you download the data to actually whittle it down to just the variables you're interested in for your project. It makes it a lot more manageable. So I do this usually in some kind of spreadsheet, keeping track of which variables I'm going to use, and then I can literally copy paste into my scripts. So I also want to take a minute to address creating constructs when you're using electronic health records, or EHRs. So many sources of EHR use codes to indicate diagnoses or procedures or medications that a participant or patient received. And there are many, possibly hundreds of different vocabularies that can be used for these codes. So after you select a data source, make sure you know what vocabulary is used. I've listed some common types here. Then you should make an exhaustive list of these codes or keywords that you'll look at the data for. So you'll want to flag these instances in the data so you can kind of narrow down your search, make notes of who meets these conditions, who has taken certain medications, that sort of thing. So a good place to start there is to look at codes that prior work has used in the literature. Also talking to clinicians who have experience with conditions of interest if you're looking at health-related data. I've also learned about some tools from the National Library of Medicine. I have the link here for signing up for that. That does require the sign up. It's a license that you're requesting. It's free, but it takes a couple of days to be approved. Included in that license, you can use this meta thesaurus, which helps you look at all these different codes. It maps different vocabularies onto one another. So you can really look at this comprehensive description of whatever condition that you're interested in. So that requires a license, but RxNav, which is through this National Library of Medicine, this is a fantastic resource. I don't think you actually need a license to use this, but when you're looking at medications, trying to look at the ingredients within specific medications, generic versus brand names, this is a fantastic resource. And then separately, this NDC National Drug Code Directory. This is great if you want to actually download an Excel sheet of all the different national drug codes for a whole host of prescription medications that you can then link to your data set. It'll give you a more uniform description of the medications that you're looking at and make it easier to flag in your data, especially if you're using something like DataDirect. My plan is to eventually have some medication cleaning scripts on our GitHub page that is forthcoming, but I'll show in that script how you can use this NDC directory to link to DataDirect medication fills. Finally, you can also use DataDirect itself. Even if you're not using DataDirect for your project itself, you can just enter it in what's called cohort mode and just do a search of ICD codes or diagnosis codes to see what is relevant or what is related to your conditions of interest. I'll talk about DataDirect a little bit more later. So now that you've got a project rationale and constructs defined, we can actually start working with the data. So this part seems straightforward, especially for data sets that are freely available, but accessing data can require jumping through several hoops. Some data sets you can literally just go to their page and download the data right now, like NISDA, the National Study of Drug Use and Health. Others you need to put in a request that can take months. In between, you might just need to create a login, and some require you to go through some registration and online trainings. So make sure you also have an appropriate place for storing the data that's in compliance with the data source. Michigan Medicine's tool for DataDirect tool, for example, you can't just keep on your desktop. I use a Dropbox Teams folder to keep those data, but there are other sources as well. Once you have your data, you often find with these large data sets, the download happens in multiple files. And so at some point, you're going to have to merge them all together. So all your variables or interests are all in the same data file or data frame. To save space on your computer, I would suggest keeping just a subset of data separate with just the key variables of interest. In some cases, if you download from online, you can select which variables you're interested in and it'll just download those variables. In other cases, you have to download the whole thing and from there you cut it down. Just be sure that you can get back to the original data somehow. It's saved somewhere, whether you store it in the cloud and it's not clogging up your computer, or you make a note of where to re-download the data and exactly which files you downloaded. So once you have your data, the next step is to start cleaning it. And I start by identifying your sample. So you may have already done this when creating your project plan, just to make sure you know how many people have your actual measure that you're interested in. But in my experience, this can take the longest in the cleaning, just because as you're cleaning the data, you're realizing different nuances to the data that might have to update your plans a little bit. So what you will start by doing is flagging who has your condition of interest or who has the elements required to be in a specific group. You further apply inclusion and exclusion criteria. This could include pulling several things together, like dates of diagnosis and diagnosis codes, age of diagnosis, whether or not the diagnosis is new or chronic, age or other demographics, whether they have comorbid conditions or not, etc. And once you get to this point of cleaning the rest of your independent variables and covariates and outcomes, it's more project specific. So it's harder to get into details here, but it often includes scoring survey measures if they haven't already. You may also decide to impute missing data if you have a smaller sample size. And you might do that in case of the smaller sample sizes and you don't want to just do a case complete analysis where you're only looking at people who have full data on different variables. So once everything's cleaned, I usually pre-register my project. So this is later than you might pre-register a primary data project, since in that case, you'll already have full control of how your variables are defined and how you plan to analyze the data once it's collected. But in secondary data, this part often for me comes later, just because I need to have a good sense of what data I'm working with before I can plan how I'm going to analyze it. So pre-registration is optional, but I highly recommend it. And if it's something you're not familiar with, it's something that people have been doing in the social sciences for many years now, but it's not as common in other fields. What I mean by pre-registering is basically publicly submitting your project plan with specific hypotheses and plans for analyzing your data. There are several reasons to do this. It encourages open science practices, including being transparent about how you're treating your data, what hypotheses you plan to test ahead of time, and it gives an avenue for others to reproduce your findings. And one major goal is to prevent p-hacking, where you're manipulating your analyses, maybe by entering extra covariates or taking covariates out until your model becomes significant. It also is meant to prevent phishing, which is very important in secondary data analysis, where you have all these different outcome variables at your disposal. You might do all sorts of analyses and then choose to report just the ones that are significant in your manuscript. But that's inflating the false positive rate and the possibility that you are finding something by chance. And so that is not sound science in that sense. So by pre-registering what variables you intend to look at, what you intend to find, or you hope to find, or think you will find, that's supposed to reduce the chances of phishing expeditions, they call them, or p-hacking. This also benefits you in that it encourages you to be organized and thoughtful ahead of time. So the project plan template that is on our GitHub page was designed so that you could basically copy and paste whole sections of that into this pre-registration document and submit it just like that. It also increases the chances that you will be able to publish null findings if it happens, especially if you were hypothesizing null findings. So a journal will find it more persuasive if you planned it all out ahead of time. What do you actually pre-register? Basically what's in your project plan, your research question, hypotheses, data, cleaning description, analysis plan, and any kind of sensitivity analyses. And you have a few choices of where to pre-register. There's the Open Science Framework that has some templates to help get you started, and that's my preferred one. You can organize your entire project there, share it with collaborators. So it's also a good kind of project management tool. Okay, so by this point, you should have a pretty good understanding of your data and the questions you can ask of it. And as I mentioned earlier, it's always good to have the question of how will I model these data in the back of your mind, so it helps you appropriately define your constructs. So for this next part, I'll outline some analyses that you may use for secondary data. It's meant to give you an idea of where to start, but there are so many possibilities when it comes to analyzing secondary data. It's hard to kind of narrow in on specifically what would be useful for your project. So I'll present this based on what kinds of research questions you might ask and how you might approach them. So first, we can ask descriptive and associational questions about our data. So descriptive questions, I mean, just those that simply ask what's happening in this population. And so these sorts of methods can just summarize what's happening. There's no comparisons, just patterns. You'll use frequencies in your data or counts, percentages, means. You can use cross tabulations, which are just basically a table that shows how two categorical variables relate to each other by displaying the frequency of each combination of the categories. You can also use descriptive plots, bar graphs, histograms, etc., to kind of show what's going on in your data. Associational questions basically ask, is X related to Y? So these look at whether two things tend to occur together without claiming whether or not one causes the other. So here you can use chi-square tests, which is basically a formal test of the differences you might see when looking at crosstabs. It tests if there's a relationship between two categorical variables. You can look at t-tests, which compare the means of continuous variables between two groups. You can look at correlations that measure the strength of a relationship between two variables. And this is where we start seeing regression enter the equation too, where you look at how one or more variables are related to a continuous outcome in the case of linear regression, but in logistic regression, you can look at the odds of an outcome happening or not happening, so a binary outcome variable. Then we have questions that are predictive or causal or comparative in nature. So predictive questions ask things like, can we predict Y based on X? These models use patterns in the data to estimate the likelihood of some outcome. The goal isn't to explain exactly why something happens, but to predict who it might happen to. And it typically has a time component where X occurs before Y. Causal and comparative questions are very similar. They ask whether or not X causes or changes Y. These methods aim to estimate the effect of an exposure or program or policy or intervention, and it ideally mimics a randomized experiment using observational data. But these often require stronger assumptions about your data and more complex designs. So the analysis approaches for these two types of questions are pretty similar. It just really depends on how you structure and use them. And there's a lot of overlap here. I just wanted to highlight a few key terms just so you're aware of different approaches. So multiple regression is just a broader term for regression models that use more than one predictor variable or independent variable. Lets you see the unique contribution of each variable while adjusting for others, like age or gender and other covariates. There's also something called difference in differences models, which is basically looking at an interaction between some time and a group variable. So this is useful in longitudinal or repeated measures data to compare changes over time between a group that experienced an intervention, for example, compared to a group that didn't. Propensity score methods are useful when when you want to balance different groups based on key characteristics. So they simulate what a randomized comparison might look like, especially if you have a smaller group and a very large comparison group and you want to match them to make them as similar as possible. Longitudinal models, where we can look at fixed and random effects within and between subjects, differences in the outcome variables, growth models. These are all helpful to look at change over time and how change in people or your observations relates to predictors. And finally, structural equation modeling. Again, this is not supposed to be exhaustive. There's lots of things that you can do, but structural equation modeling is less I'm going to mention here. This is all, it can also be used in longitudinal settings, but it's very helpful when you're testing complex pathways and theoretical frameworks. So at the bottom here, I have a site that I use frequently. It's from UCLA. They have a very useful table to help you decide what statistical test is best for your analysis based on the nature of your variables. And what I love about this site is that it also has sample code in SAS, Stata, SPSS, and R for every test type. So it's fantastic. All right, before we move on to our examples, I want to spend a minute talking about what is called a complex survey. So many of the large or national surveys use complex sampling design to get a representative picture of the population. And I emphasize representative picture of a population because this is really cool and really important. In most research, we're limited to making statements about our sample, and we have to acknowledge that the findings may or may not generalize to the broader population. But these studies with complex sampling designs are unique in that as long as you can set up your analysis properly, you can make broader statements about the entire population, which is pretty amazing, especially when you're talking about the entire population of the United States, for example. So some common designs you might hear about are area probability samples, multi-stage samples, and stratified samples. These studies use special sampling procedures that are designed to improve statistical efficiency, reduce costs of sampling methodology, and make a sample representative of the entire population. They do this using things called stratification, where they divide the population into subgroups or strata before sampling to ensure key groups are adequately represented. They use clustering, where they sample within groups like geographical regions or institutions like schools, rather than sampling individuals independently, and that reduces costs and improves feasibility of the study. And they also assign sample weights to individuals. So these are weights assigned to individual observations to account for unequal probabilities of being selected, adjust for non-response, and also they align the sample with population demographics. So to get valid population level estimates, analyses need to account for these design features using the survey strata, cluster, and weight variables that are usually given by the studies themselves. So for example, HRS will give you these data. So to do this in practice, we can use the survey package in R or the SVY commands, survey commands in Stata, which let you incorporate the design elements correctly in your models. And I'll show you how to do this in just a minute. And I highly recommend this applied survey data analysis site and book as a great resource. I think the 3rd edition just came out yesterday, maybe, which is pretty cool. This is my go-to when I'm doing these complex survey data analyses. So let's dive into one example. Since we're talking about complex surveys, I'm going to start with a project I recently worked on using the health and retirement study. So I worked on this project with Dr. Anil Zhang, who is an associate professor of social work. He was a member of our incubator program last year, which Megan will mention briefly a little bit more about that program at the end of today's session. So on this side, I've laid out our project's rationale, which we include in the project plan, but for the sake of time, I'll just zoom in. Oops, let's go back. Zoom in on the project purpose. Which was to investigate mental health trajectories of cancer survivors who had been diagnosed as adolescents and young adults, and looking at these trajectories as they age into middle and later adulthood. We landed on HRS as an ideal data source for Dr. Zhang's study. The HRS is a longitudinal panel study, which means respondents are interviewed several times over several waves. And this focused on Americans over age 50. They looked at health, healthcare, income, assets, employment. And this study began in 1992 and interviews participants approximately every 2 years. And their goal is to have about 20,000 individuals each wave. Due to sample refreshments, though, there are about 42,000 unique respondents in the data. So now I'm going to just give you a quick tour of HRS's website and how I used it for project planning for this project. So here are several links that should be useful for HRS. I'll start by going to the documentation slide. Okay, so on this slide, we have information about the study content, questionnaires, code books, data descriptions. There's also info about the survey design that you can learn more about the clustering and strata. There's video tutorials that I found very helpful for this. But let's go to code books. And it loads all the different code books for the different years and the data sources. I'll just go into this one here. And because we're looking at cancer history, I'm going to go to physical health. And of course, this is quick for me because I've done it before, but it could take some time to kind of get used to the layout of these things. And I jump down here, I see here's a variable about cancer. And it says, has a doctor ever told you that you have cancer or malignant tumor, excluding minor skin cancer? So this is the variable that we narrowed in on as being our primary indicator variable on figuring out our sample. So what I'm going to do is copy this variable name or number. I'm going to go back and see, is this variable something that is in multiple waves of HRS, or was it a one-off? I'm going to put it here in this question concordance tool, do a search for it. I see it here, cancer of any kind, and I click here this XREF crosswave equivalent, and it gives me a list of the variable names in each wave for this specific question. So then what I would do is go into my Excel sheet where I'm organizing all my variables, write down all of these variable names, and I'll save that for later pulling the data and just honing in on the specific variables I'm interested in. When you're actually downloading data from HRS, go to data products, and you could get the public survey data. There's also here restricted or sensitive data that you need special permission to use, special access to use. Whenever possible, though, I recommend you use these RAND HRS products. So RAND is a separate group that has took it upon themselves to do a whole bunch of cleaning and harmonizing of the data. It's much easier to work with these data. They've done a lot of quality assurance, and all their documentation is here as well. So here you can find longitudinal files. So this is what I started with for this study because I wanted to look at change over time. But there were some variables that weren't in the longitudinal files that I did have to pull from each of these. They're called fat files. But what it really is a wide file where for that year, each respondent has lots and lots of different variables. So I used a combination of this longitudinal file and all of these fat files. So I'll show you how that played out in a second. So going back to our slides. After we get familiar with data, we can define our constructs based on that data. So in this study, our primary cohort of interest was individuals with a history of cancer in a specific age range. For the cancer research, it's 14 to 39 and a half is how they define adolescent and young adult cancer. We already talked about the wave-specific cancer question. Has a doctor ever told you that you had cancer? We also use the date of that cancer and their age at time of diagnosis. We had a couple of comparison groups, people who never had cancer and people who developed cancer during HRS, so cancer as adults, compared to our adolescent young adult cancer group. And we had several outcomes that we identified as being interesting. We pre-registered looking at all of these, but for the sake of today's talk and time, I'm just going to focus on one cross-sectional analysis looking at the prevalence rates of people with in these different cancer groups meeting major depressive disorder criteria in the past year. So looking at, this is cross-sectionally across time, each year, each wave of HRS. And then looking at longitudinal analyses, depression symptoms that are self-reported, and how that changes within individuals and across different groups over time. So next, I'm going to bring you to my Stata code to show you a few steps in my cleaning process for this project. All the code that I am going to show you is available on our GitHub repository. Pulling up Stata now. If you're not familiar with Stata, I apologize if this is a little bit of a jumble here. And I've tried to be more inclusive of anything that might be helpful. So we're going to kind of jump around a little bit here, but you can download this and take your time looking at it if it's something you think might be useful for you. So I'm going to start out with my merging data portion. We set our working directory where our data is stored. You're going to have to likely, depending on what version of Stata you're using, set the maximum number of variables you need. So there are 17,000 variables that you're downloading here, but Stata only allows 5,000, so you need to change your default. So like I said, I'm going to start with my longitudinal file. So this is where I'm opening my longitudinal file. And then here I'm keeping just the variables instead of 17,000 of them. I'm keeping only like 100 or 200 that are relevant for my study, and saving the trim files separately. So I'm not overwriting my original data. Then in this section below, I'm going through each wave of HRS and keeping just the variables that I need. So these are kind of random looking variable names. This is why it's really important at the beginning to go through the code books and to really hone in on the variables that are useful for you. So I'm trimming the variables here for each wave. Then down at the bottom is code you can use to merge them all together. So this is what this is doing, merging it all together. And then you saved it as it's merged. So the next portion of my process, I do a lot of different data cleaning. Some of the variables or surveys haven't been scored, so I do that. I'm going to jump ahead to my analysis script just for the sake of saving you some boring details. But this part, hopefully, maybe could give you a little bit of an idea of how you can use these data in your analyses. So here we're starting with a wide file, which is what will help you look at kind of cross-sectional prevalence estimates. So here's what I was talking about, was setting up your data set with these complex survey design features. So here's survey set. This is basically telling Stata how your survey data were collected. And it includes the clustering variables, the strata variables, and the weights. And this weight right here is the weight for the specific wave that we're looking at. So the weight variables change every wave to reflect the demographics of the US population at that point in time. And so let me make sure I am actually have this open. So I'm setting this. So if we don't use the population estimates or the weighting here, and I run this, we can see, okay, this is category 3. These are people who have a history of adolescent young adult cancer. And here's 0 for whether or not they met major depressive episode criteria in the past year. So 0 is they did not meet criteria, 1 is they did. So this group 3, about 17% of them reported a depressive episode or met criteria for a depressive episode in the previous year. So these are adolescent young adult cancer survivors, compared to 8 and 7% in our no cancer and adult cancer groups. So we're seeing higher prevalence estimates. If we want to look at this incorporating design features, we use this survey command, and I'm also using a subpopulation of sample, not using people who have missing data. And then basically the command is the same. So using this tab and then looking at the counts of people in these samples. So what's cool here is that you can see actual frequencies. These are estimates of the number of people in the United States, age 50 and up, who had adolescent young adult cancer, who met criteria for a major depressive episode in the prior year in 2018. So that's 215,000 people. So if we want to see the percentage, we could see estimates here, 20% for people in the adolescent young adult cancer group. So the estimate's actually a little higher when we're incorporating design features, which is interesting and good to keep in mind when you're using these kinds of data. So in the rest of this, you can go beyond just looking at the crosstabs. You can look at logistic regressions. You can incorporate different covariates to adjust for the covariates. So that's all in this code. I've also included an example of looping through all the different HRS waves so that you don't have this long file. You can actually just loop through it. And I've also got code so you can basically append all of the margins together. So you look at them in one nice table. You don't have to sift through a whole bunch of output. And then here's code for a very rough on the edges line graph to show you what this data looks like. So you can see here across all these waves in the HRS data, we see the adolescent young adult cancer survivors have higher prevalence rates of having a major depressive episode in the prior year compared to the other two groups. Definitely not publication ready, but it's really good for getting an idea for what's going on in your sample or in the population. Then really quick, I just want to jump to the code for longitudinal analyses. For these, we use mixed effects growth models, which just basically is looking at change in depressive symptoms using the CESD depression scales over time. So because participants in the HRS responded to this questionnaire multiple times over several waves, we can see how does it change over time? Does this vary as a function of how old they are? And does it vary as a function of whether or not they have a history of cancer? So I'm not going to go through this in detail, but basically I'm using this mix command with CESD as the dependent variable. I'm slowly building up models to look at what's the effect of time. And then I'm adding an age. And then down here in model 3, I'm adding in the specific cancer cohort. So I'm just going to show you what that looks like. Again, this is kind of messy, but this shows you that in general, CESD scores as people age tend to follow a U-shaped curve where they go down around middle age and increase again. And this trend is seen in all 3 of our cancer groups, but we see a mean level difference in the adolescent young adult cancer group where they have higher levels of depressive symptoms compared to the other 2 groups. People with adult cancer are also having higher levels of depressive symptoms, but not as high as people with adolescent young adult cancer. Okay, so I am going to hop back to my PowerPoint. Okay, and next I'm going to jump into our second example using Michigan Medicine's DataDirect. So this is a project that's currently ongoing that I'm working on in collaboration with Dr. Marie-Claire O'Dwyer, who's a clinical assistant professor in the Department of Family Medicine. Dr. O'Dwyer is another participant in our incubator program. Since this project is still ongoing, we're still in the data cleaning process, so I won't have any actual analyses to show you, but I will share some of my cleaning scripts that you can use with your own DataDirect data. Dr. O'Dwyer noticed in her experience as a clinician that there seemed to be increases in adult patients presenting with symptoms of ADHD. These symptoms are also highly comorbid with those of depression and anxiety. And since stimulant medications are often a go-to treatment for ADHD, she was curious how stimulant use in adults that were newly diagnosed with ADHD, how that relates to mental health diagnoses and symptoms. So here's her project rationale. And here I'm highlighting her project purpose to investigate rates of patients at Michigan Medicine who are diagnosed with and without ADHD and with and without anxiety disorders, and how stimulant usage impacts mood and anxiety diagnoses as well as symptoms and treatments. So for this project, we're using Michigan Medicine's DataDirect, which is a web-based self-service tool, which provides access to Michigan Medicine patient data for research purposes. And there's an abundance of data available here, like procedures, diagnoses, information about different visits, medications, labs, and much more. So the sky is the limit for what kinds of health and mental health related questions you can answer using these data. So I've linked here a very useful user guide and some information on this slide here. I've also included links to an article that I wrote last year and a video of a webinar I co-hosted with Erin Kaleba from the Data Office about getting started with DataDirect. So since that webinar and article go into depth into accessing and downloading data using DataDirect, I'm not going to spend time on that aspect here today. For Dr. O'Dwyer's project, we next defined our constructs with the electronic health records from DataDirect in mind. So our primary cohort of interest was adult patients newly diagnosed in 2017 or later with ADHD and no history of a stimulant, so they're medication naive. We chose 2017. That choice was completely driven by the nature of the data in DataDirect. We wanted our patients to be stimulant naive, so we wanted to be confident they didn't have a stimulant fill in the past 5 years. The medication dispense data didn't come online until about 2012, so we can't really account for medications filled prior to that date. So to make sure our patients met our criteria, we use a combination of ADHD diagnosis codes, dates of diagnosis, and prescription medication fill data. And this is trickier in EHR than it might initially sound. Because we wanted to look at new diagnoses, we had to download data for the patient's entire history to make sure that it's not there's nothing we're missing in their history. This helps us rule out people who may have been diagnosed when they were younger, but they were coming in with concerns about increased symptoms. One caveat to that, though, is that electronic health records only go back so far. So if it was some before 2011 or so, the visit and diagnosis information is not as reliable. So keep that in mind. It's an unfortunate limitation to electronic health records, but hopefully creating inclusion criteria of starting in 2017 or later, we can kind of have a little bit more confidence that we're capturing new diagnoses. So we have a couple subgroups, those treated with stimulants, those with non-stimulant alternatives, and we're looking basically at prevalence rate of mental health diagnoses and stimulant treatment, as well as changes in symptoms. So now I'm going to turn to my R code to show you a few steps in my data cleaning process for this project. As I mentioned before, we're not quite in the analysis stage, but I'll share a couple little simple commands that might be useful for you if you're looking at prevalence estimates. Okay, so I have a couple of scripts about that you can use for opening and merging DataDirect data. One of them is for data, the CSV files or Excel files that are password protected. You have to use different packages for that. Other ones, it doesn't really matter as much. You don't have to enter a password. So I have 2 different versions of the script. So if you see that in the GitHub, that's why that's there. So here we're opening all of our libraries, our packages that we're going to use, setting our working directory to where the data are. And then before I get here too deep, let me show you, this is what the data will actually look like when you download it from DataDirect. And note that this is all, you can tell it's very minor here. We don't have many patients. That's because I made up data because it's protected health information that we can't share. So we have demographics here. Everything is labeled down here in the different tabs. We have different patient encounters, their dates, age, the type of encounter. And then we have 2 tabs here for diagnoses that I've made up. But the reason I have 2 tabs is just to show you that you're going to have to probably open several tabs of data and combine them all, because when you're downloading data from DataDirect, oftentimes you have lots and lots of diagnoses or lots and lots of encounters, and so they have to go on separate tabs. So that's just part of the cleaning script that you'll have to use. So here I'm opening first our demographics tab, I'm opening our encounters tab, and here this formats the date of encounter as a specific type of variable to make it treat it as a date variable rather than just a character string. Then I'm opening our two diagnosis tabs and combining them together in this row. And then I'm combining all the data together so that it's all in one view. And so the outcome of that is this. So all the tabs are combined. We've got our patient IDs, our demographics, our encounter IDs, our encounter date here, the ICD or term code, and the term name. From there, what is useful is to flag the diagnoses that are existing in your data. So you might have all these lists of diagnoses, but how are you going to manage it if you're trying to look for, has this person gotten an ADHD diagnosis or not? So what I start by is flagging each of these rows, giving it a 1 or a 0 if the code is an ADD or ADHD diagnosis code. So we do that in this flagging script. I've already looked up all the codes that we want to include. I have them here. This basically creates this 0, 1 variable for whether or not that specific diagnosis or that encounter has a diagnosis code for ADHD. Done the same for major depressive disorder here. And then I save our diagnoses. I also create new variables like the number of times that they have gotten an ADHD or MDD diagnosis, when their first ADHD date was on record, their age at first ADHD date, those sorts of things. And we have to be very careful about the dates. I'm going to have another kind of article written about this, but there are different dates and they don't always correspond. And sometimes someone is thinking back in their history and their kind of medical history and they say, I think that condition started in 2016. But it's not necessarily an actual diagnosis by a provider. So we have to be careful about which date we use. So I'm going to be writing more about that and hopefully sharing it with everyone soon. Then we merge it all together and I've created separate groups of people indicating whether or not each patient has an ADHD diagnosis or not, whether or not they have an MDD diagnosis or not. And then I'm saving a patient level summary of the data. So I'll show you what that looks like in a second. Open it up here. Okay, and here's what it looks like. So we don't have each individual encounter in this data set. We only have one row for each patient, but we have indicator variables, what group they're in, whether or not they have an ADD diagnosis or an MDD diagnosis. And from there, we can do certain prevalence estimates, like what percentage of people with an ADHD diagnosis also have an MDD diagnosis. So that's what this script is kind of meant to do. It's very bare bones. It's going to be a lot more complicated with all the different factors that are going into play. But just want to have something to share to get you started. So we can describe things like how old were these patients when they were first diagnosed with ADHD, 36 and a half. Of course, this is all simulated data. But then you might get to something like doing a chi-square of looking at how many patients have both an ADHD and an MDD diagnosis. And down here, you get a cross tab of how many patients are in each kind of combination of categories. We could even run a chi-square test for this. We have far too few observations though, so it's not going to make any sense. But this is the code that you would use to run that. So all this will be shared. I hope some of it will help you in whatever stage of the research project you're in. And we're always here if you have questions or need some help to get stuck. And I know Megan is going to share a few more resources for you. But for now, thank you very much and hope this was helpful for you.
Thank you so much, Emily. I think that was excellent. I assume it's going to be tremendously helpful for people listening. We will get to questions in just a moment. I'm going to go through the next slides pretty quickly, but there are a couple resources that I wanted to share that can also assist in your secondary data work. There are several places to look on campus if you're needing additional help. 3 that are outside of the Depression Center, but open to our whole U of M community. ICPSR is a massive data hub and for archiving secondary data. They have several high quality options for secondary data, such as the HRS and many, many others. They also offer many trainings and resources, such as their Summer Institute in Quantitative Methods. So we are very lucky to have them as a resource here in our own backyard and highly recommend you checking them out. Next is CSCAR, which offers trainings and free individualized consultations if you're needing help with your analysis or data management. They are extremely helpful as well. And then finally, the data office manages and oversees access to the self-service data tools such as DataDirect and also eMERSE, which offers access to clinicians' notes. And so they would be the place to look if you're looking for access for either of those tools. Next slide, please. And then some more resources that are available if you're interested in working more with our team. The first is the Research Incubator Program, which is, I think, a really unique and beneficial offering in which our team offers hands-on support for secondary data projects led by early career faculty and postdocs. So you get an opportunity to work on projects with support from our team. We provide project management. Emily leads all data cleaning and data analysis, and you end up with a product that was shared today. Both of the projects that Emily shared today were participants in this program. So I think it's really beneficial and would highly recommend you looking into it. Applications will open at the end, or actually at the beginning of May, and we'll have a deadline of June 27th. And we are hosting 2 information sessions in May and June if you want to hear more about that program. We also do offer additional webinars. So if this series was helpful and you have other topics that you'd like to hear from us about, we would love suggestions. We also have a range of written resources that we will send out as a follow-up, several long-form articles on our knowledge base, our GitHub page, our dataset library. And then we also do offer one-on-one consultations if you are just needing some help, if you're feeling stuck, if you're stuck on your analysis or just don't know where to get started. We would love to chat with you. You can always reach out to us, and that is available for no cost. So you can go to the next slide. And this is our last slide. So I think with that, we will open it up for questions. I see there's several that have come in already. And so if folks have more questions, please put them in the Q&A or the chat. I don't know that we'll get through all of them in the next 3 minutes, but we can send a written follow-up as well. I think I'll start with this question from Dr. Cranford, because I know, Emily, you have thoughts on this. In terms of data management, do you have a preference between SPSS, SAS, Stata, or R?
This is often a personal preference. I started my career with SPSS and moved into did a little Stata after that and then move into R. I think R is probably my preference. There's a lot of flexibility, a lot of libraries that you can use and download that it's freely available. It's very useful for visualizing, but it depends on the nature of the data too. So I like how the complex survey features are handled in Stata, for example. So I switched to Stata for that, but yeah, it's kind of user specific, but R is my preferred, I'd say.
Great, thank you. Next question, I think when I get to the ones that I think are best for discussion, and then we'll send more follow-up as well. But I'm wondering, this person's asking, I'm wondering more about data availability in the Michigan Medicine DataDirect. Do they have the same data as the de-identified Precision Health DataDirect, or are they completely independent tools?
That's a really great question. The Michigan Medicine version has more protected health information. So there are more requirements for getting access to them. The Precision Health version, I think they have a new name now, AI and Health Equity, or I'm not remembering exactly, but their tool is meant to be more widely available, so they are de-identified more. But as a result of that, there isn't as much in-depth information about like health. So for example, medication dispenses from pharmacies, that's not available in the Precision Health version of DataDirect, but it is available in the Michigan Medicine version. So they differ in the type of data that are available, also the requirements for access, also the requirements for how you store them. If you go to the webinar that we linked, there I go into more detail about the differences between them and the type of data available.
Perfect. Thank you so much. And I think we'll try to squeeze in one last question from Dr. Zitlow. When using longitudinal secondary data sets, do you need to address immortality bias? Example of the young adult cancer diagnoses in the HRS data.
Yeah, that's a great question. So when you are using the actual design features that are provided by HRS, those sorts of things are so mortality bias, people not being part of the sample because they pass away. Um, that is usually accounted for in the sampling weights. As far as the longitudinal analyses where I didn't use the weights, because it's a very complicated kind of statistical procedure to adjust weights across several years. Um, in that case, you can do some type of sensitivity analyses and look at, um, you can actually look at in the actual data, who were the people who did pass away, what were their outcomes like, or what did they look like before they passed away. Rerun the analyses for prior years just on the people who eventually do pass away compared to the people who don't. So you can handle that by doing some kinds of sensitivity analyses. So it's a good thing to think about.
Yeah. Okay, well, thank you so much, Dr. Urban-Wojcik. Thank you so much for everyone who attended and listened and shared questions with us. We are going to end it there since we're 1 minute over for time. And I know we weren't able to get to everyone's questions, but we will try to address as many of those as we can in our follow-up and share the tools that were shared as part of this presentation. So you'll receive the recording and all those resources in the next couple of days. And we hope to offer more sessions in the future and see you there. So thank you so much and have a great afternoon.